to this episode of Real Talk. I'm your host, Melissa Mahler, and my guest today is Dr. Delaney Gracy. She's the Chief Medical Officer and Senior Vice President of Medical Affairs for the Children's Health Fund. Welcome, Delaney.
Hi, thank you.
Well, thank you for joining us. We've had the pleasure to speak with Dennis Walta before and learned a little bit about the Children's Health Fund and some of the initiatives you're doing, particularly in Flint. Mm-hmm. But if you just want to take a moment and give us a few minute overview of the Children's Health Fund, and then we can talk a little bit more about some of the things you've been involved in and the Children's Health Fund is doing now.
Sure, absolutely. And thank you for the opportunity. So being able to talk about the Children's Health Fund and our work is really important to us being able to do the work, and obviously something very near and dear to my heart personally. The Children's Health Fund is a nonprofit. We were founded almost 30 years ago with a mission to bring quality health care to underserved kids, and particularly those with access barriers to getting care, and especially getting really good care. So it originally started in New York City, where our co-founder and president, pediatrician Erwin Redliner, was working with Paul Simon, the singer-songwriter. Mm-hmm. And they both really wanted to do something impactful domestically. They had been working together with USA for Africa internationally. Mm-hmm. But they both wanted to do something to help the kids domestically, and they both were from New York City. And so they visited some homeless shelters and were absolutely appalled by the conditions that they found kids were living in there. And so together they had this mission to bring those kids care and to figure out how to do it in a way that broke down the barriers that they were facing of being able to get there, not being able to pay for it, not having parents that could take off from their work to be able to get them there, all of those things. So with the other co-founder, Karen Redliner, they designed and built the first mobile medical clinic. And so the idea was you do your house call, but you bring your whole clinic with you. And that way you bring the care and whatever the kids need to wherever they are. And so that model was really, really effective. And so since then, it's been replicated in 14 states plus DC. We have 21 programs now, and they're all unified in that mission, bringing the best care to the kids who need it the most and have access barriers. So we do it in a lot of different ways. We always have a local partner, which is a local medical institution like a federally qualified health center or a children's hospital. And that way, the care is provided directly by an organization that the community knows, that it's their community, they recognize the name, and they also have access to specialists through that organization, which we just find that our kids have really high needs and they need that a lot. Mm-hmm. But then our program and our model allows them to extend way out from the hospital system or the clinics, and they use mobile clinics and different kinds of intervention models to bring full service care to schools, homeless shelters, community centers, health fairs, anything like that. So the whole goal is let's design the very, very best for the kids that need that the most, and then figure out how can we get that to them.
And how did you get involved in the Children's Health Fund? I read a little bit about your background and some of the work that you had done prior to that, but why don't you talk a little bit about that, and then why you decided to join with the Children's Health Fund?
Sure. I started working with underserved populations even from the start of medical school for me. And then when I decided to go into pediatrics and I worked in California, I was training in Southern California, and I had just had the gift of having this mentor who was very community minded. And so I would go to Tijuana with her twice a month, and we would work with populations there who had incredible access barriers, as well as the kids we were working with on the California side of the border. We also worked with indigenous Native American tribes on both sides of the border. And so I think early on I felt a real connection with understanding that if you're going to provide anything useful to communities, you have to bring it to where they can get it. And you have to do it in a way that makes sense for them and that they can access. So whether that's cultural, that's language, that's geographical, that's how you're offering it, that's how you're talking about it, that it has to make sense in that context. So I had this amazing dual training of when I was in California with the medical center, I was being taught best practice care. When I was working with the really, really marginalized populations, sometimes I had the reality of you had what you had, and then you had to figure out what was the best you could do with that. And it's good to learn how to do that, but, fundamentally, I believe that all the kids deserve the best care. And so after I finished training and residency, then I actually went to Columbia here in New York to get a public health degree, because what I really figured out was I love to see kids one-on-one and go family to family, but I think for bigger changes, we need to work at a community, city, population level. And it was actually when I was in public health school that I learned about the Children's Health Fund. And they said, this is a real community model, because they don't just get out of the clinic and go to the community. They also get off the mobile clinics, they go into the homeless shelters, and they really engage people where they are. So just fortunately, right when I graduated from public health school, there was an opening at the New York flagship project of Children's Health Fund. And so for the first 5 years that I was with the fund, I worked on the mobile clinics and the homeless shelters in New York City. And then after that, I was recruited to the national office. And so now I get to work with our programs all over the country and help them with program design, sustainability, raising money for them, helping with implementation, disaster response, evaluation, all of those things. So it's really, really amazing. And it gives us this incredible perspective of what is life like for underserved kids across the country, what problems are the same for them regardless of where they live, and what's really, really regional or community specific. And so I think it allows us to provide care and advocate in a way that is built on pretty deep insights with all of those layers.
One of the things I think is really interesting is the holistic approach and also the partnership approach that you take. And I think that's really important, because from the stuff that I've come to understand, you just don't walk in and say, hey, we can do this, we're doing it this way. You go in and you assess and get feedback both from the people that need the care and the people that have been on the ground. And I think that's really unique about what you do and why you're so effective at it. The other thing I thought was very interesting is the understanding that healthcare is so important from the very beginning, and that some of our populations, which you've touched upon and have written about, homeless, people that suffer from, domestic abuse or sexual abuse or migrant workers, they do help. It's both something that people like you and I actually care about and want to help, but there's actually an economic advantage to communities to help these people now. And I don't know if you want to talk a little bit about how those adverse childhood experiences or things like that impact health, both short-term and long-term.
Sure. And there was a lot of really great points that you brought up in there that I would love to touch on. The first thing you had mentioned, was the holistic model of care. And I think all of these things that you just brought up are completely interrelated. But from the very beginning, we thought that was really important, because when you work with kids and families in a homeless shelter, I mean, they can come to me with an earache and I can give them an antibiotic, and that's very nice, and it may stop their pain, and that is useful. But it doesn't get to the root of their real problems at all, because there's all of these, as we say, social determinants of health, all of the other things in their life that are impacting their health and how things, how well they'll heal and what they have access to. So, for example, if I have a kid who comes to me on the mobile clinic and I give them an antibiotic that has to be refrigerated and they have no access to refrigeration, I'm not even helping them with that. But we have a much broader model with that in the Children's Health Fund, in that when we meet a new family, we'll ask them, do you have enough food? And the answer, if it's no, we'll stop right there and we'll figure out how to solve that problem first. Because if I'm trying to teach you how to take care of your child's asthma, we're getting into all sorts of technical things about how to take the medicine and when to do it, but you're really worried about dinner, you're not going to hear what I'm telling you, and it's not going to help anybody for us to do it that way. So a huge part of what we do is that case management, the mental health support, and networking with other community partners that can provide the services that we don't provide directly. I mean, our kids need coats and socks and food in the summer and school supplies and all of those things that are really important for them to be truly healthy. So we have our part in it, and we address that part pretty broadly, but we also think that those connections are huge, and we have to figure out the ways to work together. You mentioned the adverse childhood events and toxic stress. I mean, that's something it's been an emerging part of the field, both in pediatrics and adult medicine for, more than 10 years now. But it's something that in the last couple of years, I'm really hearing people talking about, both the term toxic stress and adverse childhood events, they're very related. But the background to both of them is that when you're a child, your brain is developing from the time, 9 months before you're born to 5 or 6 years. There's an amazing amount of plasticity and development that's going on in the brain. So if you're experiencing intense traumas or chronic unrelenting traumas like neighborhood violence, domestic violence, chronic hunger, chronic verbal abuse, chronic parental stress that's trickling down to you as a little kid, all of those things affect you physiologically as well as psychologically. So they've done a lot of amazing studies where they see that, depending on the intensity and the timing of what you're affected by and the number of things that you're affected by, that there's cumulative effects that actually change the structure of your brain. And then that changes the way your endocrine system responds to stress and tension, which then changes your set points for things like your blood pressure and self-regulation and the ability to calmly communicate with other people in times of stress. And so you can see all of these pathways affect your health, your learning ability, your interpersonal skills development. So not only what you're learning from the people you're around, but actually your ability to learn to do those things well is affected. And so you can see how that totally plays into the cycle of poverty in just a really tragic way of the kids that need the most advantages are having the hardest time and having the deck stacked even more against them. So we try to develop our programming with that in mind of how do we get ahead of that? And that's why we can't just treat somebody's ear infection. We have to address those other problems so that we can really give each kid their best chance to achieve to their full potential, both psychologically, socially, but really biologically as well.
In Flint, one of the things people have talked about is that it was a community that was already facing a lot of these challenges. And right now, there's a lot of people addressing the lead contamination issue. But one of the things I wanted to spend a few minutes on is talking about, picking up from what you just said, the mental health and the stress that goes on and how you're addressing that. And I think maybe it's different or similar, but you dealt with that in Hurricane Sandy, I believe, and some other situations. So I think that's important for people to understand that, yep, you might test the water and at some point, hopefully it's fine. We've talked about before that the effects are permanent, but there's this other stress of even unknowing that you've been impacted, both from a parent and a child standpoint.
Absolutely. And there are multiple layers there that also go back to something you had mentioned before of the whole approach when we go into a community. So, any traumatized community, part of their resiliency is building their own self-efficacy and building their bonding with each other. That's part of it. And so in any kind of post-disaster, post-public health crisis event, I've always found people to be very sensitive to, are you some team from New York, somewhere else walking in and you think you know us and you think you know our community and are you going to be gone in 6 months? Why should we invest our trust in you? There's always that anybody who does any kind of response has to be extremely aware of. So as we go in and we're assessing where we need to go, and generally like in Flint, we were invited to come into the area on several levels. But we come in and we meet people, we meet agencies, and we assess what's already there. And then in working with them, is there something that we have to offer with them? So can we help build their capacity to do what they're already doing really well? Or where are the gaps in what they're already doing really well and what they don't have the capacity or resources to do? So it's always a partnership, and always taking the lead from the local organizations and from the people in the community. What do you need? What do you want? What do you already have? What do you have that's great that doesn't need to be disrupted? So I think that's the first part. And Flint is an amazing community of people. And, over and over I heard, we can do this. We just need the power and the resources to be able to do this. So there's an amazing amount of autonomy and strength and kind of grit already there, but keeping in mind that this is a community that's economically depressed. This has been going on for years. Families have been struggling for years and years before this even started. So then having the multiple layers of this, of the actual exposure to the kids, the confusion and frustration of feeling like it wasn't handled as it should have been, the ongoing confusion and frustration of feeling like you still don't even know what you're supposed to do. Mm-hmm. Are you supposed to boil the water? Are you not? When I was there a few weeks ago, the main message was you don't need to boil the water. That doesn't make a difference for lead. But then a water main broke. And so then they did need to boil the water to respond to the water main. But so then that was another message. And then people are saying, well, I don't understand. He said I didn't need to. And it was for a different reason, but people are so stressed and don't know whose messaging to trust and when to trust it. And so that's a whole nother layer of it. In how does it affect mental health? I mean, there's the direct toxic exposure to the kids that, obviously is extremely worrisome. When we see lead exposure, typically, more traditionally, what we think of as lead exposure is from like kids who crawl and toddlers eating paint chips. And that's a different kind of exposure. It's usually a much higher level, but it's much more contained in time. And it's usually, toddlers and crawlers. Here in Flint, we have families that, newborn babies were having formula made with that water. So a much earlier chronic exposure that's not really what we're used to seeing. So that's different.
Yeah, that was interesting what you just said, because I'm in Rochester right now, and I think our lead levels in the city are like 4 times higher than Flint, and other places are multiple times higher. And there's not the same focus on that, although it would be great if there was, and maybe this will help raise that on a national basis. But what you just said was the first time I think that was broken down to understanding it's at a much earlier stage and more intense.
Right. Well, and not even necessarily more intense in terms of the actual load of lead in the body, but a long duration of constant exposure that's kind of different. And so that factors in too when we're doing lead testing in the community. And so one of the things we've done is brought a mobile clinic out there to facilitate, bringing lead testing to people that otherwise weren't getting the messaging, weren't getting access for the kids, things like that. But the tricky part and the really, really critical part is if you're testing kids now, after the water problem has to some degree been mitigated, not fixed, but, they've changed the water source back to Lake Huron. But, if you have a kid who's been in Flint since they were born and now they're 2.5 and you lead test them today, it may very well be normal. But what we really have to help parents understand is that doesn't mean that it's done for that kid. That still means that kid may have exposed all along. They may have had higher numbers earlier on. And what we absolutely have to do is get every kid into regular primary care where they're going to be assessed for the developmental milestones all through their childhood. And they're going to get early intervention and enriched care. And the parents are going to receive extra education on how they can help stimulate the child's brain and brain growth to help offset whatever exposure they may or may not have had regardless of what their lead test is at any particular moment. And so that's critical. So that's one of the controversies around, should you even lead test people, because you don't want to create a false sense of security if it's okay, but you also don't want people to worry with the messaging that even if it's okay, something may still be wrong. But the message that we're just trying to really get out there is, let's get all the kids into primary care. Let's get them all the developmental enrichment that they can have. Let's get them into early intervention, and let's get them into programmings that it would be great for all kids to have all the time, quite frankly, to enrich them and stimulate their brain growth, their brain development, and their nutrition as much as possible, and be constantly assessing for if they need more intervention than that. But for these kids, it's especially important. And then there's the whole layer, as you were saying, of mental health. So, when kids are affected by lead, you see things like, decreased IQ, developmental delay, especially language. You can see ADHD-like behavior. Those are all kind of the things you would see on the exposure levels in Flint. When you have a kid that's really, really high level, like 100, which you would never get with an exposure type in Flint, that would be somebody who ate a lot of paint and got a really high load all at once. Kids are hospitalized, and that's a whole different kind of situation, and they have to have specific medicines to get the lead out of the blood. That's very different than what we're talking about in Flint, because it's lower levels, but still levels that have an impact on the brain and the body. But there's no medicine you can give to get it out at those kind of levels. So I think that's frustrating for parents too, because they want to fix it. They want to get it out. They want to take care of their kids. So the parents being the ones who are taking care of the kids, you also have to take care of the parents. And so that's where the whole mental health thing comes in, because sure, it comes in for the kids in terms of, development and behavior management and all of that. But how are their parents doing? Because their parents are stressed. Are they having access to food, clean water? And I don't know, I'm a parent of an 8-year-old, and when I'm stressed, I'm not as good of a mom as I am when I feel like I have things under control. So can you imagine with all of these layers? So there's a lot of kind of preventative work that we need to do as well, because it's well known after public health crises and traumas that, there can be increase in, pre-existing conditions and people who are prone to anxiety or depression already anyway, or alcoholism, abuse, things like that, logically when stress goes up, those things go up too. So we need to get ahead of that and get people the support and avenues for support, before things happen like that.
Are there, not just in Flint, but throughout your career and working with, children and families, is there a particular, not giving names, but is there a particular story or child or somebody that, when you go, wow, at the end of the day, wow, that really made a difference, something that stands out this is why I'm doing it?
Sure. Well, there's a couple, one disaster related story. So the intervention that we're putting together to work with some of the local organizations like Genesee Health System in Flint is to bring a mobile clinic specially designed for mental health support to the community. So we break down those access barriers again, and then have things like health fairs or stress management workshops or art workshops, anything where people feel like it hits their comfort level of where they can engage. And maybe that's in an art workshop where you're making a picture frame, but then you may talk to the other people that are there while you're there. You may normalize some experiences you're having, and then maybe you create a gift that then you can give something to somebody, and that's empowering for you as well. And maybe that's where you're ready. You're not ready to go to counseling, but maybe that's where you enter. So when we were working post-Sandy, we developed a similar project, because when we worked with the community, our first plan had been to bring in, the mobile clinic and the more traditional services. But what we learned from talking with the community was a lot of people weren't ready to access it that way yet. And so creating these other, it's a health fair and there's a stress management workshop or a yoga workshop that people would start there, and then they would become more comfortable. They'd meet our mental health team, and then they would come for the more intensive services if that's what they needed. But we had this amazing letter from a grandfather that was there and, participated in our services. And, basically told that story, when you first came, I thought I didn't need this. I was fine. And then as it went on, I became not fine, but I didn't know what to do. I wasn't comfortable. And so then he had engaged in a seniors group that we had started, that it was at a community center. It was in kind of a more neutral place. And that's where he started. And then he became one of, a really regular attendee. And then it was an amazing support for him, and he became very active in the community around that. And he, became an amazing advocate for the program. So to know that you were able to bring something that met somebody where they were and was able to help them get what they needed, whereas if you had done it by a more traditional way, they wouldn't have. I think that's very rewarding. From the shelter systems, I had an amazing family that came in, and the child had some health problems and had been hospitalized a lot of times for those health problems. The mother ended up losing her job because she'd missed so much work because of the child's health problems. That's how they ended up in the homeless shelter. And so when we first started with them, she was very protective and fairly defensive and angry because a lot of really unfair things had happened to that family. But because of the way that we provide care and the way that we're so respectful and so responsive to people's, non-traditional medical needs, that after working with that family I would see them every week for the better part of a year to get him hooked in with all the specialties he needed to do that case management, to help with transportation, to help with the asthma, and then to help the mother get mental health support that she needed to take care of herself and to take care of him. That was very meaningful. And we kept up. I still keep up with them years and years and years after they're gone. And the child became class president, and then the mom had told me that she was going to social work school once they were stabilized and out of the shelters, because she wanted to be able to give that to other people, because it had been given to her at a time where she really needed that. So it's an amazing thing to get to bring to people, and we're only able to do it because of the philanthropy. That's why you can have an intake visit that lasts an hour, and you can ask people about food and not just their ears. But it's great as a physician to be able to practice medicine that way.
What is your wish for the rest of 2016? So when we turn the page on the next year, what is something that you hope has been accomplished through the work that you're doing?
Wow. Specifically in Flint or across the country or in general?
Whichever you feel is on your
wishes.
I know. You can have more than one then.
Well, Flint is near and dear to my heart. And as I've spent, time there recently, and it's so frustrating on so many levels of what that community has had to deal with. So I would like to see real progress there. And I think some things are happening with, ensuring that the kids are getting Medicaid. But, I would love to see a solution where the families can have clean water, be confident that they have it, and really start healing and dealing with the recovery part, because still the problem hasn't been solved enough that they can even enter that phase. So, I would love for it to all be over and perfect, but not by the end of 2016. I don't think it's going to happen. But I would love it to be in a place where they can start to heal. And, we know how to do that. We know how to help them. And there's amazing, amazing teams, in Flint that are partners in that. And so many great community pediatricians that are, ready to do that work and provide that support. But the fundamental problem, that trauma, has to be removed and a lot of trust restored. And people have to feel like that they're safe to drink the water and to start and move on from there. I would love to see that.
Why don't you share the website in place that people can go to get more information or to support the work that you're doing in Flint and across the country?
Sure, absolutely. So it's Children's Health Fund, all one word, .org. And that's Children's Health Fund, like, donation fund. Sometimes we get Children's Health Fund, and it is fun, but children'shealthfund.org. And we have a great website that talks about our work with our national network of programs all over the country that do the amazing programs in schools. And then we certainly have the information on Flint and a lot of really great work we're doing with technology. We're starting to do telehealth, even from mobile clinics, to help decrease those access barriers to care as well. So a lot of really exciting things happening in the world right now that if we can decrease the disparities with them instead of just allowing them to make things even more unequal, I think there's amazing potential in what we can do.
Well, thank you for sharing a bit about what you're doing and your background, and just really helping give an understanding of how important providing health care early on is. It was very insightful. So thank you. And hope to have you back again, and we'll follow up. So
happy to. And thank you for your interest and on these topics. We really appreciate it, because we know when people hear the stories and understand what the families are struggling with, that people want to help. People are good, and sometimes people just don't know. So thank you for helping us tell that story.
Thank you. Well, that's a wrap. This has been Real Talk with Melissa Mahler, and our guest, as you've just heard from, is Dr. Delaney Gracy, and she's with the Children's Health Fund. Thank you.
Thank you.